So we're about to start with the second session from this afternoon's section. Again, we're going to have two talks, followed by a question and answer period for the whole panel. So once again, people will be circulating with specific questions. And again, there's no such thing as a bad question. Put it down, and they'll hopefully be used in the question and answer session. Our next talk was actually rescheduled, I think, for technical reasons from this morning, and usually for these types of meetings, I think most of you are aware, what's often tried is to put a kind of a summary talk that both introduces and provides a background and an overview of the topic, and then some more detailed talks afterwards. And for technical reasons, we're doing it in a bit reverse order. Today, Dr. Kocha is going to talk about some specific, in a very generalized overview of carcinoid, and I've been told it will be very unique. Again, there's a good biography of Dr. Kocha, but certainly has a wealth of experience in Canadian oncology and with this disease, so we really look forward to his talk.
Well, thank you. I'm sorry for the way things turned out. This talk was actually designed as an introduction to introduce you to a whole bunch of things, and then it would be covered in more detail in the following talks. In fact, a lot of the things I was going to talk about have been covered in quite a bit of detail, and I guess I'll go over some of them as sort of a review session, and maybe we'll even have a test or something like that. But I'll probably cover a couple of things that haven't been covered. So neuroendocrine neoplasms, and I use the term neoplasms because there's changes in terminology that are occurring. But if you've been around CNETs, you know that there's the symbolic presence of the zebra, and you probably have already heard that this is a result of the story that's often told to us in medical school, that if you hear the sound of hoofbeats, that means symptoms. Don't think of zebras, think of horses, because zebras aren't very common. So for neuroendocrine neoplasms, that's sort of true. You sometimes have to think of zebras in order to come up with a diagnosis. But I think one of the things that bothers me about this particular metaphor is that the zebra looks black and white. By the way, did you guys probably when you were very young, I know I did, had jokes about that because, what's black and white and red all over? Well, it's a newspaper or a sunburned zebra. Either one of those apparently applies. But I think when it comes to upgrading the symbol for CNET, you might think of something like this because it's not all black and white. It's actually a lot more complicated than all of that. And you need some color in your in your lives. So you've seen this diagram before, and you see there's a fill in the blank, and that's the first test. This is actually indicate the notion of the diffuse neuroendocrine system, and again, you've already had that represented to you before. I think one of the things I'd like to point out, which was not obvious before, is that when you look at the body and take it apart, either surgery or during dissection, you can see a whole lot of organs, and you can attribute these visible organs to various systems. And very often, the neuroendocrine tumors, neuroendocrine carcinomas, and collectively the neuroendocrine neoplasms were considered to be part of those organs. And in fact, it has been said that the neuroendocrine cell makes the GI tract the largest endocrine organ in the body. But I think we now prefer to look at it as its own system, as the diffuse neuroendocrine system, because they have a different type of cells, and you saw what the origins of them were. And if you think about it, this is sort of a unique system, because most other systems, you can see the organs when you open up. And the diffuse neuroendocrine system is just about one of the only ones which you can't see with the naked eye. They usually exist as single cells or small groups of cells, and with a very few exceptions, they're mainly invisible to the eye. So it's a little bit more difficult concept to get one's head around. I guess one of the exceptions to that is the adrenal gland. The adrenal gland's got the two parts, the outer part called cortex and the middle part called medulla, and the medulla is the one from which pheochromosome comes, and it's neuroendocrine. but even though it's in the same organ, the cortex is not neuroendocrine. So they're usually not visible, but they carry on a very important normal function, and the reason that they're there is that they signal. They signal to do certain very normal things. The fact that all of you were up at the table and got things to eat and this sort of thing means there's a whole bunch of neuroendocrine cells in your body right now signaling your gut to do all sorts of things. Sometimes the signals are not things you'd actually want them to do, but that's life. Oops. On the wrong direction. And you got introduced to Oberndorfer, who in 1907 first term and coined the word carcinoid. And you've seen this, I think, at least twice before. The point about it is carcinoid actually meant cancer-like. And that's a problem. And it was indicated as well earlier. It was 22 years later that he finally admitted, well, actually, it can have malignant behavior. And when you look at the carcinoid tumor, it tends to occur in a certain number of sites. There are other neuroendocrine types of neoplasms, but the carcinoid type of tumor, which comprises probably around 50% of all neuroendocrine neoplasms, occurs in those particular areas, and the most commonly in the bowel, or the bowel, and separately in the lung. Those are the two different, more common sites. And you've also seen that there's an increasing incidence for neuroendocrine carcinomas. And they have been increasing. Now, interesting enough, they've increased quite considerably, and it's one of the few types of malignancies that is increasing in incidence in the number of new ones that occur. The bowels ones have been the most common, but it is of interest to note that the rectal neuroendocrine neoplasms has been increasing most, and it's been suggested this may be a detection bias, that may be so. But the lung neuroendocrine neoplasms are increasing the most. They have increased in Ontario, I know, from 1960s to the 2000s by a factor of 10. And it is speculated about why this may be. And again, a lot of people impose, well, it's detection bias. They're better able to detect it. But there is other evidence indicating that there may be other factors that are, in fact, involved in this. In particular, some indications that anything you do to affect the neuroendocrine system, at least indirectly, and one of the more common medications we have these days are something called the proton pump inhibitors. The most commonly sold or prescribed medication in the world shuts off production of acid from the stomach, very commonly used. But when that happens, there's a feedback mechanism that says, the neuroendocrine cell says, oh gosh, there's no acid, I got to produce more acid. And it's in fact found that the neuroendocrine cells triples in numbers in those people in whose stomachs it is decreased. There was a study in the 1980s where a drug company did a study giving guinea pigs, 100 guinea pigs, proton pump inhibitors for their lifetime, and another 100 they didn't. And then within the guinea pigs, within the proton pump inhibitors, there were 3 neuroendocrine neoplasms in that group and none in the control group. I think, however, the most interesting evidence was occurred in only the last year or two. There is a rodent that has a particular defect. Now, there are cells in your body that have to mutate or change their sequencing of DNA so they can make new things. The immune cells, the ones that make antibodies. In order to react to something new, these cells have got to be able to rearrange their DNA and make new proteins to find something that matches and will neutralize or otherwise affect some invading organism or other factor. And there's such mechanisms. There's one called an aid mechanism, and they're only supposed to be turned on mainly in the lymphocytes, which makes immunoglobulins. But there is a rodent in which this mechanism is turned on permanently in all the cells in its body. Now, the interesting thing they found is that by itself, with these rodents, nothing much happens, at least in terms of neuroendocrine tumors. But once you give them PPIs, they all get neuroendocrine neoplasms. So we're quite suspicious that there's other factors that are involved with it. And you've already seen this this particular graph that shows that it's become the second most prevalent type of cancer within the gastrointestinal tract. Colorectal is certainly 10 times more common, but again, because they live longer, there's a lot more patients around. Remember, prevalence means how many people rather have this disease within the population. Does not directly deal with how many new ones they have. And this, in fact, is more common than the other malignancies. In general, by the way, the incidence of neuroendocrine plasms are increasing, and they are roughly equal to cancer of the esophagus now, and they believe that at continuing at the same rate, it is going to go up very much higher than that. So, how do we know that it's there? And this is a real problem for a lot of patients. So, carcinoid syndrome is one of the most common things that is brought up because it causes symptoms. There are other things symptoms that can be caused, especially bowel obstruction, sometimes liver-related symptoms with spread of the disease to the liver. And I think probably the luckiest people are the ones where this is found as an incidental finding at a very early stage when something else is being invented. But I've often heard the sentiment expressed, well, if only they thought about these zebras earlier, this disease would have been found earlier and it could be cured. Well, I'm not sure that can happen. First of all, you have to know, and again, this is already introduced, that there is something called the portal circulation, which is a rather unique circulation in the body. So most of these so-called carcinoid neuroendocrine neoplasms start off in the gut. Only about a third of them actually seem to develop the propensity to produce such things as serotonin, and therefore give something called the carcinoid syndrome. That is the combination of symptoms which usually results in flushing and or severe diarrhea in these patients. It may be perhaps looked at more appropriately. Oh, yeah. Gee, you guys didn't see this the whole time. Sorry about that. I was seeing it. It's fine here. So, but here's probably the best one. Because, the artery breaks off into capillaries and then it goes back into the vein and circulates around the heart. Well, there's something unique that occurs in the gut because, as you can see, a lot of this blood goes into the gut, gets broken off the capillaries, collected again into a big vessel, and then not back into the veins going to the heart, gets put through the liver, and that's the portal circulation. So tumors that start off in the gut can produce excess hormones, but since the circulation directs it to the liver, they don't get the symptoms at that point because the liver takes it out. It gets rid of it. And that was already mentioned, again, earlier in these talks. And they actually usually don't get the symptoms until the disease is in the liver, and therefore when the cancer cells in the liver make it, it produces it directly, it releases it directly into the general circulation, and that's when people get symptoms. And the point of that is, for a large proportion of these patients, by the time you get something like carcinoid syndromes, the cat's out of the bag. It's generally not curable at that point. And despite the sentiment that says, gee, symptoms of cancer, the earlier you can find it, the better chances of cure, that probably doesn't translate very much into neuroendocrine neoplasms for a majority of cases. If there's a smaller tumor that blocks the small bowel, sometimes that may be found. If that might be removed and none other are seen. Small tumors in the pancreas may be found and removed and have better chances at long-term control or cure, if I can use that term. But often these tumors do not make themselves known until they have spread, and that's just the nature of the beast. Can't do a whole lot of that. So the whole idea of educating physicians, especially in med school, well, there's lots of things I learned in med school. In fact, I remember 35 years ago learning about carcinoid tumors at a time. I still remember that, and never suspected at a time I'd be this involved with it. But in fact, if you don't use things, you don't remember them. You don't think about it. And we used to say that most family doctors would get through their whole practice life without ever seeing it. And if they never got seen, they're not going to be thought of. Perhaps directed education, especially at physicians more likely to see this, which would be gastroenterologists, endocrinologists, and probably surgeons, would be of use. But medical students do get introduced to them, but unless they take up a position later on in which they're likely to see them, it won't stick. And I don't know any way of getting around that one. Well, we've already had some excellent talks on imaging, and this is a brief review, CT scan, and somatostatin scintigraphy or octreotide scans are very important. You had some indications of positron emission tomography, and I will give you a quick clinician's view on this, because we generally believed that since most of the neuroendocrine tumors were low metabolically functioning tumors, they would not turn the PET scan positive. And we know, therefore, that the low proliferative disease, no point in doing a PET scan, as we already know, that's going to be negative. And then there are the groups of the high proliferative disease, which you can usually tell by other means, histology or Ki-67, and you know those are going to be positive. Not much point in doing a PET scan there either. It doesn't put us any further. However, we have some recent indications that this may turn out to be useful in the in-between group, the ones that we call G2 disease. And we're beginning to look at looking at that group of tumors. They're a very limited group of tumors. And if there is at all any positivity, we're speculating that it may be important to treat those with chemotherapy first and get rid of the proliferative fractions, and then turn our attention to what hopefully is left over, the less proliferative fractions. And by the way, we have observed this. We have seen patients with higher grade tumor which are treated with chemotherapy. We've had opportunity then to do surgery of them and found, gee, what was left over actually was now very low proliferative disease. And it has been, by the way, a feature in North America that not very many gastroenterologists are involved with this. I guess they're rather busy making money hand over fist doing scopes. So they haven't been involved with that, but it's turned out to be very useful to do biopsies under endoscopy, especially for pancreatic lesions. So we're getting more of those involved. And again, you saw this, just a quick review. You can see on the top left corner, the ordinary non-contrast CT scan. You can see arrows pointing to lesions. And you see when you use infusion and a multiphasic or triphasic CT scan of the liver, you can pick out things that you can't otherwise well see or maybe see at all with just an ordinary CT scan. So we've learned ordinary CT scan isn't good enough. You've got to get a multiphasic CT scan, and you've certainly seen the octreotide scan, the pentareotide scan, and yes, you've seen how useful it is in showing up where the disease is and utilizing for diagnosis, but as well, it is useful for us in terms of determining how much the isotope gets taken up, because we use it for therapy. And you've had the therapy introduced to you as well earlier today. I'd have to say, and I've already indicated to the speaker, that I was a little bit dismayed that this seemed to be representative as a new concept. But in fact, people have known about that for decades. In London, we've been treating with indium-111 octreotide. And Dr. Reed, how many therapies have we done in the last 12 years? We've done about 1,500 treatments in London, and as well, somebody did point out MIBG, and we use MIBG therapy as well. In fact, amongst the tumors we've called carcinoid, better than 50% of them are quite avid for MIBG, and we can utilize that. And do you have any idea how many MIBGs we've done? About 500 of those. So we've done that. I should tell you as well that lutetium-177 was mentioned. Just this past Monday, we received our regulatory approval and license for lutetium-177, so we're going to be doing lutetium-177 in the next several weeks. This has already been done in Canada, in Edmonton, where they've been doing it for about 3 or 4 months, and they have somewhere between 20 and 30 patients that they have done. So this therapy does exist in certain places in Canada, and we're pursuing it rather avidly. And the other thing we have to look at is this thing, chromogranin A. Here is the molecular picture, the atomic picture of chromogranin A. And for those of you who remember your high school chemistry and maybe your university chemistry, this will make a whole lot of sense to you. It probably doesn't make a whole lot of sense to most people, but just to indicate that this is something that's often put out with neuroendocrine carcinomas. We can measure it to blood, and it serves to help us in terms of dealing with the disease. Now, Therapies. Okay, lots of therapies. Somatostatin, analog, surgical resection, surgical debulking, liver resection, sometimes liver transplants, and select patients, radiation therapy, chemotherapy, tumor ablation of the liver, hepatic arterial therapies, and biotherapy. Not only that, we can break it down to radioisotope therapy. There's several different isotopes that are available and utilized in various methods. And for chemotherapy, there's a topside platinum for poorly differentiated disease, streptozotocin combinations for pancreatic neuroendocrine carcinoma, temozolomide combinations have turned out to be useful in both well-differentiated and less well-differentiated tumors. In fact, there's some indication that they may be more active than a topside platinum. So can it respond to chemotherapy? Well, yeah, it can. And hepatic arterial therapy, bland embolization, or giving chemoembolization that goes mainly to the tumor in the livers, or we have done radioembolization in the past, or various combinations of that. And we have biotherapy. Interferon has been around for several decades with Dr. Oberg's work, but we now have everolimus, which you've heard about, sunitinib, which you've heard about, and as well vandetanib. Now, vandetanib is one that's undergone a trial specifically for medullary causa of the thyroid. It has been positive, and AstraZeneca is now applying for its approval on that particular disease. So there are a whole lot of therapies that are available, despite what might otherwise be said for neuroendocrine carcinomas. And then the question comes up, okay, how do you know which is the best one? And the answer is, we actually don't care much, because this tumor is different. Whereas for most common cancers, you have one big chance of treating them in the beginning. There's maybe 50-60% of patients who will be well enough to get second-line therapy, and generally only 10% or less are well enough to get third-line therapy. Well, this doesn't hold for neuroendocrine carcinomas, because these patients can be long-lived. They can be around from multiple levels of treatment. And for us, or at least for me, this means the more of these therapies I have available to utilize in some sequence, the longer I can hold off and control this cancer. So it is not generally that useful to try to compare these. It's actually much more important to find more therapies that don't cross-react with these, and that you can otherwise offer a treatment sequentially, because most patients can be around for all of these therapies, unlike most other malignancies. But I promised in the objectives that there should, in the abstract, there should be problems, and there are problems. First of all, this looks like it shouldn't be a problem, but there's been changes in the classification, and again, this was alluded to. The WHO classification that came out just at the end of November, just 6 months ago, has introduced some changes. The neuroendocrine neoplasm of the digestive tract, and the working principle. The working principles are that these are diseases that are unique by their peptide producing tumors, and they share certain neuroendocrine markers. And they include both well and poorly differentiated tumors. That's important. I'll tell you why in a minute. And the premise is that all neuroendocrine neoplasms have a malignant potential. There are still people out there who say, this is a benign cancer. You don't have to worry about it. Not true. And here is, I think, one of the real cruxes of it, because you see this is the WHO classification, and WHO in 2000 had the term carcinoid, and then the poorly differentiated types of tumor. So back in the year 2000, they changed their classification to what you see out there. The importance of that is we've actually taken the word carcinoid out of this. Since then, 10 years ago, it was no longer legitimate to talk about carcinoid tumors, because they are neuroendocrine tumors. Now, it has been very difficult to get the word carcinoid out of the medical sphere and even out of the patient's sphere. And in fact, until just 5 days ago, I was going to say it's as difficult to get carcinoid tumors out of use as it was to find Osama bin Laden. I've had to change that, and maybe I can say now it's as hard to get carcinoid out of the medical profession as it is to get Gaddafi out of Libya. I wonder how much longer that will. But then in just 6 months ago, they have changed their classification further, and you can see that there's allusion to NETs, the neuroendocrine tumor, and then there's NECs, the neuroendocrine carcinoma. So the word tumor tends to be utilized for those collections of cancer cells that are all in one spot and do not seem to show any malignant features. Once they take on the ability to be able to spread to lymph nodes, for instance, they are carcinomas. If they invade, they are carcinomas. So there's been real problems with the terminology. And what the WHO and European Neuroendocrine Tumor Society has said, well, all of those have their uses in specific situations. We'll subsume all of that under the term neuroendocrine neoplasms. So that to me makes a lot of sense, and I'm expecting to utilize the term neuroendocrine neoplasms as the terminology. The other problem is that the AJCC, the American Drug Commission, in their stagings, now both the European WHOs and the AJCC have something called the TNM classifications that they utilize. The AJCC produced a new classification just a year ago in January. For the first time, they actually recognized neuroendocrine tumors as its own specific group of tumors. Before that, it was found mixed in with various other groupings. It wasn't recognized, but for the first time, they did that. But in fact, some of these stagings they didn't necessarily agree with the WHO. So there is a discrepancy from, at least in the appendix and pancreas, of how you stage the disease. That won't have much implications for you, but it does for us. And the AGC still does not recognize the poorly differentiated or mixed neuroendocrine carcinomas within that group, whereas the WHO does. However, there's one other problem to me, which is a much more major problem. You've seen slides before, and you see these brown spots amongst all these blue spots, and you probably learned from the previous talks, well, these brown spots are staining for something. Well, in this case, they're staining for Ki67. Ki67 has turned out to be a very important proliferative marker for us. So a lot of tumors have a small proportion of the cells staining positive for Ki67. In fact, the majority of well-differentiated neuroendocrine neoplasms are G1, where the proportion of cells is 2% or less than 2%. I think it actually should be more liberal, but it's right now recognized as less than 2%. But you can get higher amounts, such as this, and we know this means trouble because these are much more aggressively, often rapidly progressing cancers, and you can even see great variations depending on the part of the tumor. Well, one of the things that happened with the AJCC is that they produced preference in terms of what are the minimal standards. And what they said is, well, Ki67 is optional. We'll go along with the number of mitoses per 10 heart rate field. Well, to the Europeans, and actually to us, that isn't good enough. It's not optional to us. We've got to know what that is because we really determine therapy on that. The high G2 and G3 disease often needs chemotherapy. The low G1s don't need that. And even though that's made optional, the AJCC, by the way, is the standard that's supposed to be adhered to within North American institutions. We in Canada have really mainly said we do not think that is optional. We do not go along with our American colleagues. Are there any Americans here, by the way? Raise your hands if there's any Americans. And I don't even see Dr. Coles here, so I can safely say that the Canadians do not go along with their hubris-prone colleagues to the south. And in fact, I've been in international meetings in the last month or two where they said, what's going on with you guys? Why is there this transatlantic discrepancy between using Ki67s and the G status? I say, wait a minute. We don't go along with the Americans. We go along with you guys. We need it. We actually demand it. I've had to phone pathologists a number of times to get this done. Interestingly enough, I've also had the experience of getting pathologists reporting this as between 2 and 20%, and that's G2. But really, I actually need to know the actual number. That isn't really good enough. And I've had to call these people up and say, I really need that number as close as you can determine it. And fortunately, all the pathologists have been very gracious and have done that immediately. But just to know that there's actually a cultural difference between the American, ourselves, because we go along with the Europeans. Come on, you can do it. There you go. So here's the the other problem. And unfortunately, when we fix this, the font should come all right, but that doesn't matter much anyways. Let's see whether this part works.
It's a very indolent tumor. I really have no treatment to offer you right now. My suggestion would be that we simply continue to observe things, and when you have symptoms, we can talk about treating you then. But there's nothing to be done right now.
So, as far as we know, this tumour tends to grow very slowly. It can be present for a long time. We haven't any real treatments that we can use at the present time, but we can control symptoms, and we'll...
I'm not sure what these patients are so concerned about. Really, we've got patients who are gone within months. These guys could go on for years sometimes, so really they're lucky.
Well, how many of you experienced that sort of thing? And I've seen lots of patients who've reported these things to me. I find it hard to believe, and maybe they're stating it, but the sentiment that there's actually nothing to do for these cancers. You saw from the treatments, actually, there are things to be done for these cancers. And what are these patients bellyaching about? I've got patients who are going to make it 4 or 5 months with much more serious tumors, and you guys are lucky because you got these tumors that grow much longer, so quit bellyaching. I often can't believe that people get told that, and I've actually had a surgeon somewhere in this country say to me, and I don't think he uses his exact words, but what he said is, well, you got carcinoid tumor, it's essentially benign, go away and come back when you're symptomatic, sort of thing. And that is a problem for patients. And it belays a problem with certain groups of physicians who should know better and should be educated to do better about knowing about that. And patients have to fight that one out. We have to really make a lot of efforts to educate certain specific parts of the medical community about this. Well, the other sentiment I've seen expressed is guidelines. Guidelines are wonderful things, and I've heard at previous of these meetings patients saying, listen, all we need is guidelines. My physician can read it, they can follow the guidelines, and everything's going to be hunky-dory. Do they still use that term hunky-dory, or is it cool now? I guess it's cool now. Sorry, I'm a bit old. And I think that I would like to take issue with this. In order to use guidelines, you have to have more than just knowledge, because that's what guidelines basically do. Is that they give knowledge about that. But knowledge is not the only thing that one utilizes when one develops expertise in this. That is, the fact that somebody has expertise in this does not mean, well, they've got more knowledge, and gee, you can get this knowledge out of the guidelines, so why bother? So I think some of you came to this meeting by airplane, right? By airliners. You came on airliners. So when you fly back after this meeting, if the airline says to you, gee, we're rather short of pilots, but the guy read the guidelines last night, so we should be able to know how to fly that airplane. And they say, well, yeah, a little bit young, and but they can say, yeah, and I know I've been a private pilot and I can fly a Cessna, but despite that, whether I read guidelines or not, I wouldn't be able to fly a modern airliner. Why? Because you need to develop the skills to do that, and the experience counts. In fact, it's probably not that much different from driving a car. You probably didn't give your teenager the keys to the car as soon as he turned 16 without any other instructions. It does need the development of beyond knowledge, a lot of skills, and you need the professionals who have a lot of skills and experience in doing this, so you can actually fly. And medicine and treatment of urinary tumors is no different. So, in addition to I missed turning that. You can fly, right? Okay. So, in addition to knowledge, you got to have the tools and skills, and you have to have the experience. There's a lot of literature. There's a lot of literature on this. it takes usually about 10,000 hours or 10 years to have enough experience to really get good at things. And this seems to at least refer to all sorts of situations, from being the star pianist, the violinist, the golfer, the chess player, this sort of thing. You need the experience to develop that amount of expertise. And therefore, I'm going to make the contention that guidelines are rather limited in usefulness. The inexperienced would find it difficult to utilize. They don't have experience or skills in doing this. So giving this to your family doctor, even if he knew able to look it up and knew where it was, he probably wouldn't be very well able to make use of it. And the other people who don't need it are the experts, because they're doing it long enough. This is so well internalized that they can do this automatically. They don't need it. And just as a point of reference, when you're driving the car and you're coming up to the stoplight, you don't reach down and look at your guidelines to see what you should do next, right? You know what to do. You don't compare on manuals and read the manuals as you're driving just so you know you got guidelines of what to do. You've done this enough, you're experienced enough, you know what to do. And it's the same thing which experts do. Moreover, the guidelines can be very basic and simple, and there's a whole lot of situations in which there's such a level of complexity, guidelines just don't cover it. And if you wanted to produce the guidelines that could cover every situation, I think I've calculated with various combinatorial mathematics that you probably would need more molecules than there is on the Earth to try to represent all these situations. It's practical and really impossible. So inexperienced can't use it, and the experts don't need it because they've got it already internalized. But they may have some use, because the experts like me who make it looks good on our publications. I mean, it looks good there. And sometimes when you make it, they may be used by the government to provide funding, but even there, it's a real problem because they can take a real hard line on it, such as this. They are fraught with abuse that can be overinterpreted, and you find your access to certain things is limited because of a very strict interpretation of those guidelines. And again, it doesn't deal with complexity. So if you're the poor person with a very complex complex problem with the disease, you're not going to get it. So I find that, and I wish to put the situation that the guidelines are very limited usefulness, as much as people seem to think ab initio that it really is useful. Well, a lot has been said about the multidisciplinary team, and that means you do need to get expertise together in many different domains. You can, for instance, drop in the medical oncologist, and wow, look at that, people! Oh, hi, Dr. Kocha. I won't. That guy's a real hand. Nuclear medicine physician. Sorry, Robin, is Robin gone? He's gone. Okay, you doesn't have to worry about this. So that by the way, is the SPECT CT. It's a combination of both the nuclear medicine scanner and a CT to localize things. I didn't have the heart to tell them that they forgot the patient on this particular case. And believe it or not, we actually have a radiation oncologist in our team. It's rather unusual.
We expect to be able to give radiation to the liver, and normally we don't study liver actually in radiation oncology. But new techniques, such as new imaging techniques, machines like this can provide us with techniques that can radiate with dose in very specific locations within the liver.
Wow, is this a real liver?
No, so this is a model of the liver that helps us determine the different lobes of the teaching model.
Oh, told you he was a ham. And surgeons, but not just one type. Sometimes surgeons can observe two types, but we generally like an endocrine surgeon, or at least a general surgeon with special training, and a hepatobiliary surgeon. Both They usually hide behind masks, and they're much more difficult to see. So this is the best I could do for this one. And what has not been talked about a whole lot now is the interventional radiologist.
The interventional radiologist, looking at one of our patients who has had RFA along with liver resection of neuroendocrine metastases to the liver. And just looking at this follow-up scan done yesterday, you can see that these previous lesions that were enhancing quite significantly in the liver are now completely resolved. So a combination of surgery and interventional radiology therapies.
And an endocrinologist, we had the benefit of an endocrinologist. This is ours. I was hard put to find them in any particular setting. Mainly you see endocrinologists sitting or standing and using paper, and more recently computers, and that's sort of about it. But we do have an endocrinologist, Dr. Van Oom, who's an endocrinologist connected with neuroendocrine tumors at our particular place. And very importantly, the nurse. And the nurse that I'm going to show you is the super nurse that I work for, and some of you may have met
Our
Rosemary.
patients, when they come to see us, the word that they state to me all the time is they feel hopeful. Hopeful meeting physicians who understand the disease, who can provide them with knowledge, and they feel knowledge is also empowering.
And we also have a pharmacist that specializes in neuroendocrine carcinomas. Now, I'm going to have to pre-warn you, when they finally got this working, this is the one thing that didn't turn out right in terms of orientation of the pictures. So this person is actually not lying down on the job. So have you got the everolimus ready yet?
It'll be out of 5 minutes, but we're good to go.
Great. We have a cardiologist who's also involved with this. I know in Halifax they go directly to the surgeon, but we have a cardiologist very heavily involved in all of this. He works in another part of the city, and I couldn't get a picture of him, but I do understand that some people consider him a caricature of himself. And pathologist is also very important, and we had the benefit of that during this presentation. They can usually be seen with things stuck out to the front of their heads, like that. And you put this all together, and what we define as useful and actually absolutely necessary in multidisciplinary groups is that we have a neuroendocrine tumor board. So this is a depiction of a neuroendocrine tumor board. It can go something like this.
I think that the worry with Doug is that we don't have always a consensus standard. That's not necessarily a bad thing. I don't think that every single patient with resectable liver metastasis should get chemotherapy. I can't really give you a list of reasons why. I think if this were a 40-year-old healthy person with this scenario.
I'm running short of time, and so the question is, well, does this actually all work? Does it make a difference? Well, I think we have data that it actually does, and this is a graph looking at median survival. Now, be very careful with median survival. Median survival is the figure that we use to relate to a population. It never relates to any particular person. It's the point at which 50% of the people have either had the disease come back or they have lived to. It also means it's the point at which 50% of the people live longer than. And you can see the first figure. It was actually quite low until 1987 and 1988 to the 90s. It seems to higher. Purposely picked that point because that's when octreotide, somatostatin receptor inhibitor, became available. And then we have two institutions. There's the one Uppsala, where Dr. Oberg, one of the pioneers, came from, and there's also the Moffitt Institution, which Dr. Larry Coles runs, a very important and pioneering physician. And since he's not in the room, I guess I don't have to be too effusive about it. By the way, did you notice during his talk that he actually had more trouble advancing the slides than he had advancing the field? But you can see that there is a considerable improvement in the median survival of the population based on whether you attend those institutions which can be considered center of expertise. In fact, increases almost threefold. So we think that this is very important, but more than that, we think it results in an emerging standard, and which is this one. We used to say that patients probably should have somewhere along the disease course the benefit of a center of expertise and our neuroendocrine tumor board. Well, in the last couple of months, several people in Europe and ourselves are changing that, and we're saying, no, every patient should have the benefit at least of a neuroendocrine tumor board and maybe as well a neuroendocrine center of expertise before any therapy is ever undertaken in their tumor. So that's the new propaganda that I wish to add. So this has evolved. There's many changes and approaches in policy and policies. I should note that one of the observations we've had is that 2.5 years ago, we had absolutely no prospectively randomized clinical trials in neuroendocrine neoplasms at all, ever in that history. And that's considered the gold standard by the evidence-based people. If you don't have a prospectively randomized controlled study, some people in fact say, gee, you can't do anything unless you have a phase 3 randomized study. Well, now we have 5. Just within 2.5 years, we have the appearance of 5 such studies. So things are really progressing rather rapidly, and this is the end of the zebra, the end of my talk, but not the end of neuroendocrine neoplasms. Thank you.
Thank you very much, Dr. Kocha. That was great.